everything in green, a normal looking GCC. There's no red or green areas in the significance printout on GCC, and the Tisnet curve also looks very well. Just to show you a clinical correlation, so this patient who can see, you can pick up a small wedge defect in the inferior pole, more clearly seen in the red free defect. And again, this correlates well with the superior defect on visual field. And again, the defect is very well highlighted on a 10-2 visual field. So if you correlate these changes with the OCT nerve fiber layer changes, you can see a small dip and a blue area in the lower part, which is tagged as red in the significance map. Now, if you look at the ganglion cell complex, now again, you can see the blue area and the circular pattern is lost. So there is a classical glaucoma ganglion cell loss in the inferior part below the horizontal raphe, which is correlating very nicely with the superior defect on a 10-2. So in a good, usually what is very important is that you correlate all your clinical information, what all you're getting from the clinical picture, the disc findings, the visual field findings, the nerve fiber layer, and many a times early changes of ganglion cell complex can help you pick up very early glaucomatous changes, and they can correlate well with the field defects also. Again, similar example, you can see a nerve fiber layer defect in the inferior pole correlating very well with the loss of ganglion cell in the inferior part, and some subtle defect happening in the superior part, so something like a pre-perimetric glaucoma. Now we also have options of wider view where you can correlate. Yeah, so I'll be just quickly winding up. So you can correlate the nerve fiber layer thickness with the macular cell in a wider scan, which gives you a beautiful depiction of how the glaucomatous damage is happening. And you can also pick up glaucoma progression with GCC assessment over a period of time using trend or event-based analysis. The advantages of GCC imaging over the nerve fiber layer imaging is in patients who have tilted disc or large areas of peripapillary atrophy, or maybe retinal nerve fibril artifacts, or patients who have high myopes. Now, again, in very advanced glaucoma where the nerve fiber layer has floor defect, the GCC imaging can be of some role. And especially when we talk about normal tension glaucomas, again, GCC can pick up early changes much before the visual field defects. The GCC is limited in patients with ARMD and macular pathologies like ERM or diabetic macular edema, and we cannot visualize the GCC clinically. So, like we can pick up the nerve fiber layer defects on clinical examination also. Now, again, if you have a large area of peripapillary posterior staphyloma, then GCC may falter, but still, even in high myopes, this is better than assessing the nerve fiber layer defects on OCT. So I would like to end up by saying that GCC has added a new dimension in imaging of glaucoma, and it correlates very well with the visual field defects and the nerve fiber layer defects on the OCT. And in early glaucoma, especially normal tension glaucomas, it may have an edge over assessing the retinal nerve fiber layer by OCT. In moderate glaucomas, all three parameters perform equally well. And in advanced glaucomas, again, the GCC may have some advantages over the retinal nerve fiber layer defect, but a clinical correlation is a must. Thank you so much.
Thank you, Dr. Parul, for bringing the colors in OCT printer to life. Next, I'd like to invite Dr. Karthikeyan Mahalingam for his talk on imaging in pediatric glaucoma. Dr. Karthikeyan, please.
So welcome, Dr. Karthik. He was assistant professor in RP Center before he left us and joined.
I first thank Shika ma'am and Vinay.
I think some delay is there.
Yes, sir, you're audible. There's some delay here.
I first thank Shika ma'am and Vinay sir for giving me this opportunity. I'm going to talk about imaging in pediatric glaucoma. Like, there are no conflicts of interest, no financial interest, and most of the images are taken from this book, our book only, published under Vinay sir and Shika ma'am. You can refer for further images there. As we go for the imaging in pediatric glaucoma, it's always challenging because most of the kids are uncooperative. They'll be crying in the OPD, they will not open their eyes, and most of them have poor vision. They will have nystagmus, which is also making it difficult to further imaging. And most of the equipments are made for adults, so it is difficult to use it in children. And for as for posterior segment OCT and all, there is no proper normative database to say whether which percentile they like. So what to do? First, we have to ask if they're very small children, we'll ask them to not to feed before coming to OPD. They will sleep or they'll be quiet. That time we can do examination. Or else we can, while examination, we can distract the child or we have to sedate the child. We can use this portable device. Vanessa used to use this kind of portable device to see the fundus examination. Or if the child is not cooperative or any other thing, then we have to go for examination under anesthesia. That is the last resort. So imaging can be anything, starting from clinical picture of anterior segment or posterior segment to UBM and OCT or HRT. So now I'll be mainly talking about the anterior segment OCT and UBM. See, this is the normal for cooperative older children. We can use this kind of OCT which is measured in a sitting position. During anesthesia, during examination under anesthesia, we can use this flex OCT. Initially, Shika ma'am was talking about a lot about aqueous angiography using this OCT. Or other thing is during examination anesthesia, we can use this UBM to measure the look at the anterior segment. So what can we see? In case of corneal opacity, where we can't see the AC details clearly, we can use this OCT or UBM, where we can see whether the AC is deep or not, whether iris is attached to the cornea or whether how is the lens, etc. In this image, you can see the central corneal edema along with the detachment of the EMPDL complex. Okay, we can also differentiate based on OCT and clinical pictures using differentiate CHED from primary congenital glaucoma. In CHED, there is a uniform thickening of the cornea, increased thickness in cornea everywhere, and the thickness is more than 1,000 microns. In case of primary congenital glaucoma, you can see the thickness is more in the center, and as you go on the periphery, it is thin, and the image also is saying peripheral clearing with central opacification. This is an image taken from the article by Shika ma'am. Here in the ASOCT images along the HAP striae shows that there is with circumferential protrusion. Here the mushroom shaped protrusion of in the areas of HAP striae, and you can see DM and PDL separately. In these two images, we can see the in the area of HAP striae there is defect in the pre-Descemet's layer. In these two images, we can see the Descemet's membrane detachment along with the membrane in the area of HAP striae. So this in a case of type 1 Peters anomaly, UBM showing the iridocorneal adhesion. So UBM can also help in identifying the ciliary body or any problem pathology in the ciliary body which can't be detected using ASOCT. See, you can see a ciliary body cyst here. We can see a mass in the ciliary body in this area. This is a case of Serge-Weber syndrome showing dilated episcleral vessels. This is the cause of one of the cause of raised intraocular pressure in case of Serge-Weber syndrome. This is a UBM in case of nanophthalmus showing accumulation of fluid in the supraciliary region. So before operating in nanophthalmus, it's always good to do a UBM to detect any supraciliary fluid because this can predispose to malignant glaucoma. So we can avoid it by prophylactically starting atropine study by Vinay sir. They showed that presence of Schlemm's canal, that's identifying Schlemm's canal, is a predictor of success after SLT in patients with JOG. So patients in which as normal angle, we can identify the Schlemm's canal and they have higher success rate if you do SLT. And this is an image in a patient where the GAT post gonioscopic assisted transhumeral trabeculotomy. That we can see the de-roofed Slem's canal. Here we can see the Slem's canal. Here it has been de-roofed, and there is a cleft seen here. So this is a Casia to aesocity, 360-degree aesocity of a patient. And this is the control eye, normal eye, showing a trabecular meshwork and normal iris insertion. Here you can see this is a trabecular meshwork. The iris is inserted in the posterior trabecular meshwork. Here the iris is inserted in the middle trabecular meshwork. Here the iris is inserted in the anterior trabecular meshwork. Here you can see a membrane in the angle. Here you can see the ciliary body attached to the trabecular meshwork. Here you can see some abnormal tissue or membrane in the angle. These are all patients with primary congenital glaucoma showing variation. That is, these are first showing anterior iris insertion, and this is abnormal membrane and adhesion. This is a 360-degree angle analysis.
Karthik, you can wind up.
Yes, ma'am. Okay. Okay. This is a ASOCT showing cases of a 3D angle recording of trabeculectomy along with trabeculotomy, showing the ostium, trabeculotomy ostium, and trabeculotomy. A 2D image showing the trabeculotomy ostium, and is the trabeculectomy ostium. Okay, I thank my alma mater AIIMS and my professor, guide and mentor Vinay Gupta sir. Thank you.
Thank you, Dr. Karthikeyan, for the insightful lecture. Next, I'd like to invite Dr. Ankur Sinha, who has joined here after his talk on neuro-ophthalmology, and he'll be speaking to us on visual field progression. Dr. Ankur, please.
Thank you, sir. Thank you, RPC, and thank you, Vinay sir, Shikha, and everyone here for involving me in the RPC Ray program. So I'll be just sharing my slide. So can it be seen?
Yes, they're seen.
Okay. So good afternoon, everyone. And I'll just talk about in brief about tools for assessing the progression in the visual field. Now, that's a very confusing subject, and I don't know whether I'm going to clarify or further confuse. So let us start with it. So there are various factors which can affect the follow-up of a visual field. The first and foremost is the IOP control, which can have a neurophysiological, psychological effect, or they can be a change in the vascular physiology. The pupil size, the electrolytes, the learning effect, and the actual progression which we actually want to look for in the visual fields. So there are various methods to assess the progression. The first and foremost is the clinical assessment. Then we have got event analysis in the form of guided progression analysis, GPA, and glaucoma change probability, GCP. Or we have trend analysis of global indices, which includes an MD, PSD, or VFI, point-wise linear regression, cluster trend analysis, and then there can be certain sophisticated approaches, which I think I'm not going to discuss here. So clinical assessment, this lacks standardization. One compares the grayscale, decibel sensitivity, global indices, pattern, and the total deviation plots. The approach is subjective, and it is based upon the knowledge and the experience of the observer. But there are various studies which have shown fair to moderate intra-observer variation in clinical assessment. So I'll put up this field here. So this is a visual field of a patient who has advanced glaucoma, and we have 10-2, and even on the 10-2, we have a large area which is blind in these visual fields. So there are just 3 lines which are also the edge points which are available to us for manual assessment, and there is no GPA or VFI available here. Also, we can see that the mean deviation is not going to help because it is severely depressed. And we see as the patient slightly worsens or is not able to do the field as he could do, the PSD decreases, which improves with, which is called an improvement in the PSD. So what is left here is just a small amount of visual field, but we can see that the more or less the fields are stable over a period of 11 years. And what we see here, there's a little bit of change in the visual field or improvement. This is probably because of low test reliability as the patient is aging up from the age of in these last 11 years. Now we move on to the event analysis. Now, what event analysis does is it compares the two baseline fields with the test in question with the event that is included, and there are event that has occurred, and there are no interim tests or in between tests which are included in this. So progression can be identified as worsening at the each visual field point location. So issues here is the progression can be identified in one but not in later because the test retest variability by the patient of the patient. It is also dependent upon the baseline visual fields. It does not provide you any rate of progression, which is important for us to know. Now, GPA is a point-wise event-based analysis. It is based upon the pattern deviation plots. It picks up the points which are outside the 95% confidence interval of test retest variability obtained from a stable glaucoma patient. So basically, those people who tend to have more test retest variability are trying to be excluded here. Now it needs two reliable baselines. If three or more locations worsen in two fields, two fields, it is called as possible progression. If three or more worsen in three fields, it is called as likely progression. Now, this is not usually affected by the diffuse change in the media opacities like cataract or something else which is going on in the patient. So it may also give high false positives in patients who have large test retest variability and response errors by the patient. It may not be very effective in advanced glaucomas where we have a lot of depressed points which are beyond the depression of 15 to 20 decibels. And all fields need to be in one perimeter in the older versions, but the forum overcomes this need now. Now, this is another visual field over a period of 12 years. So what we see here is there are lot of points we have crossed where they have marked this as cross. Now, these points are outside the range of calculation and they are not available for further assessment of progression. Then there are certain points which we can see labeled as hollow, half-filled or full black circles. And these are the points which are progressing, which are found to be progressing on 1, 2, and 3 consecutive visual fields. So what we see here is the patient has more or less been stable from 2010 to 2018. But then after 2018, the patient was lost to follow-up and then comes back after 4 years. And then he has a significant loss of vision, which we can see, significant loss of field, which we can see in this progression analysis. Now we move on to the GCP. It was first used in the early manifest glaucoma trial. Again, change in more than 3 locations in 3 consecutive visual fields is considered as significant. It is again based upon the pattern deviation plots and compares the 2 baseline visual fields, which is merged with GPA. Now, definite progression, whenever we label in GCP, it is associated with a mean change of approximately 2 decibels from the baseline. And this mean change should come in approximately 5 significant points, which will be significantly depressed beyond a point. So GCP, I think, is these box plots in GCP are not used these days, but it is just to mention here that these are arranged from best to worst. The best is on the top and the worst point is on the bottom. The 50th or the median point is here and right in the center. And this is the 15% from the bottom and this is 15% from the top. So when we follow up these patients, when this median is going down, then there's a global depression of the visual field. And when this tail elongates, that means more and more visual field points are getting lost, or the defect is getting larger and deeper gradually. This is what is the indication of these box plots. So I think I'll skip all these slides. Now, this is the glaucoma progression analysis we were talking about. So here we can see that the patient was absolutely fairly well controlled from 2010 to 2015. Suddenly, the patient comes up with these defects. And these defects are because of this disc hemorrhage and nerve fiber layer defect which has come up. And these 3 fields are done just to show the patient that you are progressing and something is to be done in this patient. Now we move on to the trend analysis. The trend analysis is an application of linear regression or its modification on a series of visual fields. It provides change over a period of time, so we can have the patient whether it is rapidly progressing or a slower progressor. It assumes the change rate of change is linear, but we have to understand that a decibel scale as such itself is not linear, so there can be some variations. It requires minimum of 5 to 6 visual fields, and it can be applied to any global indices or clusters, individual points, or even events which have occurred in the past. Now, VFI is one of the form of trend analysis which scales from 0 to 100. And the early part of VFI, when the sensitivity is good, it is based upon the pattern deviation plot. But when the sensitivity goes down below 20 decibels, it takes up the mean deviation to calculate the VFI. Now, this VFI is not affected by the media opacities and reflective errors, again, because it is largely based upon the pattern deviation plots. So VFI, which is based upon the pattern deviation plot and the mean deviations in the visual field, can be used as a complementary to each other to assess progression. So I would just like to say that there is no single index which can give you progression in each and every case. And in the early diseases, the global analysis is very less helpful because it will just give you a global form of the visual field which is happening, but there could be increase in the focal defects, which is going on in the early loss of glaucoma. So this is a VFI of a patient over a period of another 12 years. We can see. So we can see
Ankur,
the
you'll have to wind up. Ankur,
Yes,
Ankur,
sir.
we have
So this is the last
time.
slide. This is the last slide, sir. So I think so. This is the linear regression on mean deviation in the PhD. And in the end, I just like to thank you again once again, sir. Thank you, sir.
Thank you so much, Ankur. Can we have um, the international lecture? Can my slide be seen?
Yes,
So I think I'll just stop share. Just a moment.
yes,
Yeah.
yes.
Okay. Can you see my slide?
Yes, sir. They are visible.
Are we okay? So basically, we are having this international lecture by Professor Janie Wiggs, which is a recorded lecture. She's the Paul Austin Chandler Professor of Ophthalmology at the Harvard Medical School, and is the co-director of the Glaucoma Center for Excellence. She is vice chair of the clinical research. She's a clinician scientist who's specializing in genetics of inherited ocular disorders, especially glaucoma, and directs the certified clinical diagnostic laboratory where patients undergo tests for inherited retinal disorders, early onset glaucomas, and primary optic atrophy. She's an associate director of the Howard Laboratory and an associate chief of research at the Mass Eye and Ear Hospital in Boston. She serves as the chair of clinical research and is the co-director of Glaucoma for Excellence, as well as a leader of the genetics diagnostic section of the Ocular Genomics Institute at the Mass Eye and Ear at Harvard. She's a recipient of numerous awards, including the Alcon Research Award, as well as a Weizerman Merit Award to prevent blindness. So, Arnav, can we have her lecture, please?
Yes, sir. Just a minute, sir.
He's the recipient of the International RPC Oration Award this year. And we are really honored to have her virtually on our session today. Arnav, are the slides not ready? The presentation?
I just I'll be sharing my screen now.
Yeah.
Okay. Is the screen visible?
Yeah. Arnav, it is.
My name is Janie Wiggs, and I'm delighted to give this talk, the RPC International Oration, on the role of genetics in glaucoma diagnosis and treatment now and in the future. I have no disclosures relevant to this talk. So glaucoma is a leading cause of irreversible blindness throughout the world. And in order to preserve sight in people who are affected with this disease, early detection and treatment are important. But disease screening and risk stratification are challenging, and many affected individuals remain undiagnosed. So how can genetics help with this problem? Well, genes that are associated with glaucoma can be used for genetic testing to identify people with increased risk of developing disease and before irreversible optic nerve degeneration occurs, and also to identify glaucoma patients who have risk of developing more severe disease. So, as you know, the glaucoma can occur across the lifespan, and all forms of glaucoma are inherited. Early onset or childhood glaucoma, juvenile onset primary glaucoma, congenital glaucoma, developmental glaucoma, these conditions are inherited generally as autosomal dominant or autosomal recessive traits. They're caused by rare mutations in genes with large biological effects, and they tend to occur in families. Initially, we used these families for linkage studies to find these genes. Now we're using whole exome and whole genome sequencing to find genes in these families. Currently, there are 12 known genes that cause these conditions. In contrast, the adult onset forms of glaucoma, primary open angle glaucoma, angle closure glaucoma, and exfoliation glaucoma, exhibit complex inheritance, which means that not a single gene can cause these conditions, but multiple genes in combination can result in a disease. Individually, these susceptibility variants have small effects, and we find them by studying cases and controls in genome-wide association studies. For adult onset primary open angle glaucoma, there are more than 100 genetic risk factors associated with disease. So genetic testing is very important for both early onset disease and late onset disease. And I'm going to show you examples of both of that, starting with the early onset forms. So in families where there's early onset glaucoma, it's important to consider that there's a genetic cause. So, for example, in this family, the mother was diagnosed at age 20 and she had had surgery for glaucoma. Her children, she had 4 children, her children were getting older and getting to the age where she herself had developed glaucoma, and she was worried that she may have passed the disease on to them. So she came to us and wanted to have genetic testing. So we did genetic testing, and we found, in fact, that she did have a mutation in a gene known to cause primary juvenile onset primary open angle glaucoma, myosin mutation. And we also found that 2 of her children also had this mutation. Her 18-year-old son, who already had slightly increased intraocular pressures, and her 9-year-old son, who had not been examined with eye disease. So we could recommend to her, based on this genetic test result, that for the older son, who already had some elevation of pressure, to consider perhaps starting to treat that pressure to give him the best chance of preserving optic nerve function. The youngest boy, also with the mutation, needs to be followed to see if his pressure begins to increase. And then the 2 middle children who don't have the mutation don't have any need for increased disease monitoring. So this kind of genetic testing can be done for all of the genes that we currently know cause early onset glaucoma. The problem that we run into is that because we have just a small number of genes, only 12, only about 20% of the time do we find mutations in these genes in affected patients. So there's likely to be more genes to be found, and to facilitate novel gene discovery, we're using whole genome sequencing and ethnically diverse populations. Using this approach, we've recently found a new gene, EFEMP1, in the Filipino population, and we're excited to start a new exome sequencing project with Dr. Vinny Gupta at your institution to also look in the Indian population. Now, turning now to adult onset diseases like primary open angle glaucoma, we can also use genetic testing for these diseases, but it's important to remember that unlike the early onset forms where a single genetic variant is sufficient to tip the balance from health to disease, In the adult onset cases, each individual variant has a small incremental effect on genetic risk, and only in aggregate or in combination with other genetic variants can the disease threshold be reached. So it doesn't make sense to test these families or these people for individual genetic variants. Instead, we need to test for a group of variants or a risk score. So recent methods have been developed to allow for calculations of polygenic risk scores, which are based on a genome-wide association study and can test for thousands of genetic variants at one time. The way that this works is that all of the risk variants are added up in each individual person in a population, and then that person is ranked against other people to see where they fall in terms of how many risk variants they have. So people that have the largest number of risk variants are in the 90th percentile or higher, and they have the highest risk of disease. People with the fewest genetic variants are in the lowest percentiles, and they have the lowest risk of disease. So we have found that this kind of approach is very useful for patients with primary open-angle glaucoma. People with glaucoma and the high polygenic risk scores, that is in the 90th percentile or greater, have been shown to have more severe disease compared to people who are in the lower percentiles. They have an earlier age of diagnosis, higher intraocular pressure, thinner retinal nerve fiber layer, increased likelihood of progression, greater need for surgical intervention, and there's an increased rate of glaucoma conversion in people who just have ocular hypertension. So doing this kind of testing on patients with primary open-angle glaucoma can be quite useful. Glaucoma suspects who have low or intermediate scores maybe could be watched less aggressively than those that have the high scores, where we would expect increased surveillance and possibly earlier prophylactic treatment. The same is true of glaucoma patients with lower intermediate scores. We might treat them just as we would normally treat glaucoma patients, but those with the high scores could be, it could be argued that they should have more frequent surveillance and earlier treatment escalation, even perhaps to have earlier surgery. So I just want to say a few words towards the end here on treatment. Some of the genes that we've discovered are potentially amenable to gene-based therapies. And probably the one that is closest to that is myosin. Mutations in myosin can cause dominantly inherited juvenile open-angle glaucoma and also early adult onset glaucoma. The mutant proteins accumulate in the endoplasmic reticulum and cause cell death. Mice in humans without myosin do not develop disease. Recently, in the last few years, it's been shown that gene editing using CRISPR-Cas9 can remove mutant myosin and can lower intraocular pressure in a mutant mouse. So this kind of therapy could potentially be developed for humans with myosin mutations. There's a number of other gene-based therapeutic targets that have been entertained over the last couple of years, including the TEC and angiopoietin-1, angiopoietin-2, angiopoietin-like 7, and TXNRD2 and ME3. So to summarize, genetic testing using early onset glaucoma genes can identify carriers of high impact mutations, allowing for surveillance and early treatment. Genome-wide association studies have identified hundreds of POAG risk variants, and polygenic risk scores define individuals at high disease risk and with more severe disease with earlier onset. Pre-symptomatic polygenic risk stratification could allow for increased surveillance and earlier treatment of people with high genetic burden. And targets for gene-based therapies are emerging. There's a lot of future work that we need to do for early onset glaucoma patients and for adult onset glaucoma patients for polygenic risk testing. We need new genes. We need to understand factors that can modify risk. And it'd be interesting to integrate polygenic risk score testing with family screening. Thank you very much. I'd like to acknowledge the people that have worked with me on these projects, the International Glaucoma Genetics Consortium, and a number of people that are working in my lab and on other specific projects. Thank you very much.
I think that was a great ending, a good talk by Professor Jenny Wiggs. And we've shot over time, and I think we can close the session now.
And we would like to thank each of the participants and our alumni for having, we are really honored to have you all here. And it was great listening to all of you. We could not, have the question answer round, but we can discuss offhand whenever we meet next about any of the newer things, any queries that we have in everyday's life.
Thank
So
you.
Thank you, Gazella. Thank you, Bhagwat. Thank you, Arnav. Thank you, all of
Dr.
you.
Anbu
Thank you,
has
Shikha.
left, he's messaged, so he had an OT.
Yeah.
So thank you,
Okay.
everyone. Thank you, sir.
Thank you.
Thank you so
Thank
much.
you, sir. Thank you,
Thank
ma'am.
you, Anna, for
Bye.
moderating the session.
Yeah.
Okay.
Okay. Thank you.
Thank you.
Recording stopped.